Chapter 5, Assessment, Nursing Diagnosis, and Planning. Okay, so these are the theory and clinical objectives for this chapter. So we said that assessment was the first phase in the nursing process, right? And that it was basically just the act of collecting information about your client, organizing that information, and determining its significance. So as the LPN, you will contribute to the assessment phase of the nursing process by collecting data or gathering data um, as a will be your role in this assessment phase. So we have, different types of physical assessments that we might do. So understand an initial assessment should be done by a registered nurse. And then, like I said, as the LPN, you'll be collecting data um, to help contribute to that assessment piece. But if a person is initially admitted to a hospital or home care setting or whatnot, that initial assessment should be done by the registered nurse, and then you can contribute to that. So we have different types of assessment that can be done. Um, the type of assessment performed is dictated by the patient's current health status. A complete assessment is performed when the patient, so like when I said, if they're just admitted, um, when so when the patient presents as stable, so if they're in a stable state and have no immediate life-threatening events, then we can do a complete assessment. The goal of the comprehensive assessment. The goal of the comprehensive assessment is to obtain enough information that will allow you to develop a complete list of nursing diagnoses. So that registered nurse, remember we said, will be developing that diagnosis. And so doing a comprehensive assessment allows them to be able to develop a complete list for that patient. The list is then, prioritized, and a determination can be made for which diagnosis should be addressed initially. Now, if the patient is unstable or is experiencing some type of life-threatening event or whatever, a focus assessment is done. And so a focus assessment focuses on one specific um, problem. So they're trying to focus on something, one specific problem. They're trying to meet the immediate health needs of the patient, right? And so, regardless of the type of assessment that's performed, it's important to remember that an inaccurate or an incomplete assessment can result in a faulty plan of care for that patient. And so, as a result, it could even cause some adverse outcomes for that particular patient. Also, I want to bring to your attention about the comprehensive assessment being based on 11 functional um, healthcare patterns, and they're located in your book on page 60, box 5.1, Gordon's 11 health patterns. You can see them there. I'm not going to go through all of them, but um, so when we're talking about health, perception, health management patterns, nutritional, elimination, exercise, activity level, their cognitive ability, their sleep rest patterns, self perception, role, relationships, sexuality, their coping abilities, their values and belief patterns. And so for each of those patterns, you're going to assess their functional state. And under functional, you have what's their present function, their personal habits, their lifestyles and cultural factors and age-related factors, and then any dysfunctional. So functional and dysfunctional. For dysfunctional, you have a history of dysfunction. Do they have a history of dysfunction? Diagnostic tests, any abnormalities in their diagnostic tests, and any risk factors that might be related. So you want to assess each of those things as well. Okay, so um, During the assessment phase, there are a lot of different ways you can collect data. You can collect data via the interview, you can collect data via checking the patient's medical records, or you can collect data via a head to toe assessment. So an interview, remember we said you have subjective versus objective data. Subjective data is going to be what your patient tells you. So the interview is going to be a way that you collect subjective data because it's basically you're interviewing the patient. It's not a social interaction. The nurse interviews the client to obtain the health history and identify the needs of the patient. So what's going on with the patient and your communication. So you need to make sure you have good communication skills. Communication is verbal and nonverbal. Your body language can say a lot to the patient. Does the patient feel like you have time for them or not? Are you holding the doorknob like you have to go? Are you watching the clock? Are you standing with your arms crossed like you don't really want to talk to them? What's your facial expression? So a lot of these different, so communication is a good part nonverbal. What are you telling the patient nonverbally as well as what you actually say um, verbally? So you want to make sure the patient feels relaxed so that they're able to open up to you and be honest about what's going on with them. So, like I said, the interview is going to give you your subjective data. So, you should have three basic stages in the interview process: your opening, the body of the interview, and the closing of the interview. So, during the opening of the interview, that's when you're going to be establishing a rapport with the patient. So, you want to always make sure you introduce yourself and tell the patient what you're going to do. You're not going to just go in, like we said before, touching the patient, talking to the patient, and they don't know what's going on. So make sure they're comfortable. There's no, minimum noise. They have some privacy. You're not going to be interrupted by doctors doing their rounds or, um, you know, if they have guests, do it at a time when they don't have guests, unless they want their family involved in the process, then have them there or whatever. So we should be developing a rapport during that opening, and part of developing that rapport. When we walk in, we introduce ourselves and tell them what we're going to do. Um, and then the body of the interview, that's actually when we're conducting the interview, asking the questions that we need to ask. Is in the body of it. And in the closing is when we're summarizing information, summarizing what we've talked about, summarizing what the next steps are, um, allowing your patient to be able to ask questions during this phase. Um, if they got questions about the interview process, what was said in the interview, what the next steps or whatever their questions might be, making sure we allow them time to do that as well. So the medical record is going to be objective data. It's objective data because it's things that we can observe, right? So ideally, if we can check the patient's chart before we make first contact with the patient, that would be ideal. I know it's not always ideal to be able to do that, but if you can check the patient's chart, because that could trigger some things that you might need to ask in the interview before you actually get to the interview, or give you a heads up on certain things or whatever. We can get a lot of information from our medical record. That's where our face sheet is, our physician's order, any nurse's notes, any other discipline's notes, uh, the physician's notes, therapy notes, dietitian notes, all those other people's notes, your medication administration record, your treatment administration record, any history of surgeries, any other medical history, any diagnostic tests they might have had or results, lab results, um, what was their admission assessment and concurrent assessments, are their fall risk, what's their plan of care, so all those things we should be um, looking at. We can get some family history um, or whatnot, but as well. So all these things, we can get from the medical records. And like I said, ideally, if you can check it ahead of time, that would be ideal. But I know it's not always ideal. And then we have our physical assessment, which is also going to be objective because it's things we observe, things we measure. So the physical assessment is a significant source of objective information. The nurse uses inspection, auscultation, palpation, and percussion to obtain information about the patient's health status. And so the physical assessment is also when we start to get our data validation, start validating the data that we've gained from our subjective data and other sources. So, for example, if the patient told you that they've had a fever for the past 2 days, and then the nurse's observations or measurement of the temperature is 101 um, or 100 degrees Fahrenheit, then that would demonstrate to the nurse um, that yes, this patient is experiencing um, a high temperature or fever. So, and that's where, so we'll do our head to toe assessment. So your assessment actually starts as soon as you walk in that room. What do you see? You should be inspecting things. What does your patient look like? What's their general appearance like? What's their skin color looks like? What's their affect? How they breathing? What's the room around you look like? Um, how what can you see? So just soon as you walk in that room, what kind of things do you see? um, just automatically, inspection starts as soon as we walk in that room. What do we see? So if we start with the head, we're gonna do an inspection of the head. So our level of consciousness, what's your patient's level of consciousness? Are they fully awake? Are they drowsy or lethargic? Are they stuporous? Meaning they require painful stimuli to arouse, or are they comatose? So what's your patient's level of consciousness? Um, Also, their level of orientation. Are they alert and oriented to person, place, time, and situation? You want to assess that as part of your 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 head. Are they able to communicate with you? What's their communication abilities like? We're talking about eyes, and we're going to go into more detail with each of these areas of assessment as we go throughout the course. But what are their eyes like? You should be checking for perla, pupils equal, round, react to light, and accommodate. That's a part of their head assessment. So all that's a part of the head assessment. And like I said, as we go throughout the term, we'll go in more detail with each of these and how to do it. So your vital signs, we've gone through this already on how to assess vital signs. But when you're assessing vital signs, what's their temperature? Remember all the ways we can check a temperature: oral, temporal, um, tympanic, axillary, rectal. Um, what's their pulse like? When you're assessing their pulse, you want to make sure you assess the rate, the rhythm, the strength. Um, Remember, where your all your pulse points are. Typically, we're going to do a radial, which you can do for 30 seconds and multiply it times 2. However, is that um, if that's irregular, you want to do an apical for a full minute. Apical is left midclavicular fifth intercostal space. So you should do an apical for a full minute. Also, when you're assessing your pulses, make sure you assess the person's strength as well. So is it was obviously 0 is absent. We don't want absent, but +1 would be weak, +2 would be normal, +3 would be bounding. So we want to make sure we identify that. What is your respirations? What's the rate of respirations? Also, their pattern, their depth. Are they using accessory muscles to breathe? Do they have a cough? All those things. What's their oxygen saturation like? Their blood pressure. We want to be assessing their blood pressure as well. So, also remember pain. Pain is our fifth vital sign that we should be assessing. Don't forget how to assess that. OPQRST, right? Onset, provocation versus palliation. What makes it better? What makes it worse? Quality. Is it throbbing? Is it stabbing? Is it burning? Um, region or radiation? Where is it located? And does it spread anywhere? Severity on a scale of 0 to 10, 0 being no pain, 10 being the worst pain. And timing. So timing, we didn't, as well as onset. When did it start? How long has it last? Does it come and go? And all those things. So you want to make sure you assess all those things when you're talking about assessing a person's um, vital signs. And also, vital signs that are abnormal should be reported to your registered nurse or your charge nurse um, immediately, because there's going to be some additional things that need to be done. So you want to report abnormal vital signs to your registered nurse or charge nurse immediately. Depending on the clinical setting, the sometimes you can delegate your uh, vital signs to a nursing assistant if the patient is stable, right? So keep those things in mind. Vital signs are usually checked once every shift, especially in a hospitalized patient, and maybe once a day if they're in like long-term care or rehab or something like that. So again, we're going to go more into detail on how to assess these things later in the term. But a head to toe also includes heart, lungs, abdomen. In an acute care setting, your heart, lungs, and abdomen should be auscultated at least once during the shift, right? If it's a home care setting or something like that, every visit you should be assessing heart, lungs, um, abdomen, or whatnot. So as far as we'll talk about how to assess heart sounds um, and what normal and abnormal heart sounds sound like. Lung sounds, we're going to be teaching you how to do that. You're going to be listening for, does the patient have any adventitious lung sounds such as rales, wheezes, crackles, rhonchi? Are the breath sounds diminished or whatnot? So we'll be listening for all those things as well. Abdomen, we're going to be assessing um, what is what is the shape of it? Is it round? Is it flat? Is it concave? Is it soft? Is it hard? Um, Now, with abdomen, our pattern in which we assess is different. So we want to inspect first, then auscultate, and then uh, palpate. Typically, LPNs won't percuss, but you want to always going to inspect first. So what does it look like? Do you see any wounds? Do you see any bruises? Do you see a peg tube um, or whatnot? Do they have an ostomy? Things like that. Um, what was their last bowel movement? If a person has not had a bowel movement in 3 or more days, that could indicate a problem to you. So you should be assessing last bowel movement every time. What's their appetite like? Do they have nausea, vomiting? We want to auscultate. Second thing we want to do after we inspect is auscultate. We're going to be auscultating for um, bowel sounds. So our bowel sounds positive in all 4 quadrants, or are they absent, which would be a problem. Before we say bowel sounds are absent, we need to listen in each quadrant for 5 minutes before we say absent bowel sounds, because if we say absent, then we're saying there's a big problem going on here. Are they hypoactive? Are they hyperactive? Normal bowel sounds, we should hear between 5 to 30 bowel sounds a minute. So under 5 would be hypoactive, over 30 would be hyperactive bowel sounds. So what are our bowel sounds like? When we're auscultating and when we're palpating, we're going to palpate also. We should be palpating. Do we feel any lumps or bruises, or do they have pain when we palpate or whatnot? And so we should not feel organs, but that's what kind of things are we palpating for. Now, when we auscultate and when we palpate, we want to do it in a specific order. We want to start in the right lower quadrant, work our way up to the right upper quadrant, then move to the left upper quadrant, and then down to the left lower quadrant, because that's the pattern of the colon. So if there is anything in the colon, we want to be making sure we're moving it in the direction of going out of the body. So that's the pattern we want to use um, when we're auscultating and palpating the abdomen. So we should be assessing their extremities. You know, how well can they move their extremities? Um, what's their skin? What's the skin turgor like? Is it good? Poor skin turgor could indicate dehydration, the color, the temperature, peripheral pulses. Remember, we said what are all of our peripheral pulses? Make sure you remember you got to identify them. So where can you feel a pulse? You can feel the radial, obviously, at the wrist, the brachial in the bend of the arm, temporal, the head, carotid. Remember, we're palpating both sides to feel if they're equally strong. Except for carotid, you want to make sure you do one at a time because you don't want to decrease blood flow going to the brain, causing the person to pass out or whatever. So carotid in the necks, your femoral in the groin, popliteal behind the knee, dorsalis pedis on the top of the foot, and posterior tibialis, the back of the ankle. So you're going to be palpating all of your peripheral pulses, right? So if a patient can't follow commands well, then do they have spontaneous movement in bed? If they do, make note of that in the chart. Does the patient guard one side? You know, that could be something. Are they not able to move their extremities effectively, indicating there's some impairment? Is their skin color? Is it pale? Is it cyanotic? Which would be bluish in color, meaning there's a decrease of oxygen. Um, you know, what's their skin temperature like? Are they warm? Are they cold? Or whatever? Do they have edema? If they have edema, is it pitting or non-pitting? So we're going to be assessing all those things. So a part of our assessment would be also assessing any tubes or equipment that might be attached to our patient. So do they have oxygen? If so, is it set at the right liters? Do they have the right device, such as nasal cannula, face mask, or whatnot? Do they have chest tubes, right? Um, Make sure you make note of the anatomic insertion site if they have chest tubes or some type of drainage tubes or whatever. Do they have NG tubes? Check the marking on the NG tubes. Is it pulled out more, indicating we might need an x-ray to make sure it's still in place? If the NG tube is connected to suction, then what's the amount of suctioning coming out? What's the color of the suctioning coming out? Do they have a peg tube in place? Is there any drainage? Is it if this continuous? Is the patient sitting up as they should be to prevent aspiration? What's the peg tube site itself look like? Is it red around the area or whatnot? You know, do they have ostomies, a colostomy or urostomy or whatever? What's that site look like? Um, do they have urinary catheters? What's the urine look like coming out of the urinary catheter? Um, you know, is it properly attached to the bed? Is it properly attached to the person's leg to prevent pulling on it? You know, dressings. What do their dressings look like? Is it drainage? Is it intact? Do they have a pulse ox attached? Do they have traction devices attached? Is there any pain associated with any of these devices or things like that? As part of an assessment, the nurse asks for information from the patient. This information is a subjective indication of illness perceived by the patient and is called what? The answer is two. So symptoms are subjective indications of illness that are perceived by the patient. Question 3. Linda knows as part of her nursing assignment that she is to review and update the nursing care plan on her patients. The answer is 3, every 24 hours. So the nursing care plan is reviewed and updated every 24 hours. Um, but necessary changes can be made anytime. Okay, so um, once we gather all the data, the database is then analyzed for any cues that might indicate deviations from the norm. Um, so we got to analyze, get everything analyzed once we complete all of our, gather all of our data. We sort the data, and then the data is grouped or clustered. And so basically, data clustering is grouping data to help the nurse form a clear picture of the patient's health status. And that could be done in a variety of ways. It could be based on the person's body systems or nursing theories or just a variety of different ways that they might uh, group it. They could use Maslow's hierarchy of needs or whatever, right? Then they're going to determine what data is missing. And then from there, they can make inferences about the patient's problems and help them to um, prioritize and come up with uh, nursing diagnoses. Okay, so what did we say the nursing diagnosis was? We said it was uh, a clinical judgment concerning a human response to a health condition or a life process or um, vulnerability for that response. So we said it's different. A nursing diagnosis is not the same as a medical diagnosis. The medical diagnosis actually labels the illness, whereas the nursing diagnosis defines the patient's response to the illness. So, what is their response to the illness? And remember, actually writing and developing the nursing diagnoses is the sole responsibility of the registered nurse. But you, as the LPN, will need to understand how they come about writing this nursing diagnosis because you need to be able to, first of all, understand why they wrote it, and then be able to contribute and add to it and say, hey, maybe you need to assess my patient for this particular nursing diagnosis or whatever. So you need to understand it as well. And so it indicates the patient's actual health status or the risk of developing a health problem. So they actually have the health problem or they have a risk of developing a health problem. So you got three different types of nursing diagnosis. You have a problem focused nursing diagnosis, a risk diagnosis, or a health promotion diagnosis. And so a problem focused one would be focused on a problem that they actually have. So we'll go with this one. Anxiety related to situational crisis and stress as evidenced by restlessness. So you're always going to have in this problem focus, you're going to have what is the issue related to. And so the related to section is the cause of the problem. So the related to section is going to be the cause of the problem. So anxiety related to situational crisis and stress. So situational crisis and stress is the cause of the problem, right? And then you're going to have and um, as evidence by. And so these are going to be the defining characteristics or the signs and symptoms that you see in the person. So, anxiety related to situational crises and stress, which is your cause, as evidenced by what are the signs and symptoms that you're seeing? Restlessness, as evidenced by restlessness, right? A risk factor are things that your patient might be at risk for based on their situation. They don't have the situation yet, but they could be at risk for it. So, for example, risk for infection as evidenced by inadequate vaccination and immunosuppression. So because they are not vaccinated and they are immunosuppressed, they could be at risk for infection or risk for infection as evidenced by uh, open stage 4 wound or whatever, something like that. And in a health promotion is just that things that you're trying to do, you know, to promote health or whatever. So, example, readiness for enhanced self care as evidenced by expressed desire to enhance self care. So we're saying they're ready to start learning about self care because um, they've expressed the desire to do so. So that as evidence based by section is going to be what you're seeing. What are the signs and symptoms that the person is showing? Okay, so prioritizing our problems. So once we come up with our nursing diagnosis, we have to prioritize those problems. Which ones do we need to tend to first? And so we're going to prioritize them based on their level of um, need. So our life-threatening situation or things that the patient might consider very important are going to be classified as high priority. And so remember, establishing these priorities is not a static activity. Once you do it, that's it. No, adjustments are made as changes in the patient's situation occur. And so typically we'll use one way we talked about prioritizing is using Maslow's hierarchy of needs. And so remember, Maslow's hierarchy of needs is when you have that triangle on the bottom where your physiologic needs, so your airway, your breathing, your elimination, bowel and bladder elimination, your nutrition status, things like that are in that physiologic level. Then next is safety and security. Do you feel safe? Do you feel secure at home? Things like that. Love and belonging. Do you feel loved? Do you feel appreciated? Do you have family? Do you have that social connection? Self-esteem. What's your self-esteem like? Do you have self-respect? Things like that. And then self-actualization. A lot of people don't really reach self-actualization. That's the optimal level. I've accomplished everything I want in life. I feel secure in myself and in my opinions and whatnot. And you don't intimidate me by your opinions and things like that. Like I said, a lot of people don't reach that top level. So the idea with Maslow's hierarchy of needs is if one level is not met, they're not motivated to move to the next level. So physiologic being the first level, if I'm having difficulty breathing, right, then I can't focus on anything else. You're trying to teach me about my new diagnosis of diabetes, but I can't focus on that because I'm having difficulty breathing or whatnot. And so that's how we're gonna, use that to as one of our ways to prioritize using Maslow's hierarchy of needs. So what are our high priorities is how, and so we need to prioritize those nursing diagnoses. Question 4, which of the following sets of assessment data is most likely to be present with the nursing diagnosis risk for infection? So the answer is going to be 4, abdominal incision, decreased hemoglobin, and indwelling catheter present. So assessment data used to make a nursing diagnosis um, include medical history, physical examination, laboratory analysis, and data from the nursing history and assessment. A risk for nursing diagnosis describes human responses that may develop in a vulnerable patient. So option 1 and 2 contain data that indicate an actual infection, and option 3 has no data to indicate an increased risk for infection. And so option 4, with those things being present, having an incision having a catheter, having a decreased hemoglobin. Those things can put a person at risk for infection. Okay, so we said the next step in the nursing process is the planning phase, right? So we said during the planning phase, our diagnoses are prioritized. So we have to prioritize which ones we need to tend to first. We're going to establish our goals and our outcome. We're going to establish the interventions, develop interventions to help reach those goals. What interventions will we put in place to reach those goals? And write our care plan down. Care plan is not finalized till it's actually in writing. So we have to write our care plan down. And your registered nurse is the person that should be writing that care plan. Now remember, we said always include the patient um, and if they want their family um, when you're setting goals. It's not the nurse's goals, it's the patient's goals. The nurse may have a goal for the patient to walk 100 feet by the end of the week. However, the patient may only not want to walk 100 feet. The patient may only want to walk to the bathroom and back safely. That may be the patient's goal. So if you've set all these lofty goals that the patient has no desire to meet, they're not going to work towards meeting those goals. So make sure you include the patient and if they want their family when you're setting goals for this patient. And remember, we said we're going to set short-term goals and we're going to set long-term goals for our patient. So your short-term goals are set within 7 to 10 days or, by the time they get discharged. Whereas your long-term goals are going to be longer, maybe several weeks or even months. Could be, your long-term goals. And you want to make it specific, identify, um, be specific. If don't just say if we want them to be able to lift lift a box in 2 weeks. I don't know. I'm just making something up. Be able to lift a box and something. Don't say. Be specific. 5 pounds by the end of the week. So give a time frame on that as to when that should because it should be measurable. Should be something we can measure. We can measure if by Friday they are able to lift 5 pounds. If by Friday they're only able to lift 1 pound, then they haven't reached that goal. So it should be measurable. Our goals should be um, measurable, things that we can measure. Okay, so your interventions. So interventions are actions that are performed by the nurse to achieve the goals or the expected outcomes that were developed. So interventions should. Um, so our goals are based on, what were the problems we identified with our nursing diagnoses. Um, and so it all relates back to that. And so then our interventions should be specific to what our expected goals and outcomes are. So they're actions that the nurse will perform to achieve those expected outcomes or goals. Right. Generally speaking, nursing interventions may involve assessment, teaching, counseling, or actual hands-on treatment. So we got three categories of nursing intervention. You have independent nursing interventions, and those are nurse-initiated interventions. And so they fall within the scope of nursing practice and they can be performed without any orders from a healthcare provider or physician or whatnot. You have dependent nursing interventions, and those require a physician or some type of healthcare provider to write an order before they can be implemented. Um, for example, you cannot administer a medication without a doctor's order. So that will be considered a dependent nursing intervention. And a third category of interventions would be interdependent interventions. And interdependent interventions are collaborative. And so these interventions require the actions of multiple members of the healthcare team. So, for example, a patient who has a nutritional deficit will require interventions from the physician, the nurse, and the dietitian. And so the physician may request a consultation with the dietitian. The dietitian will provide expertise regarding the dietary requirements, and the nurse will assist with ensuring that the patient follows the prescribed dietary guidelines, right? So you have all of those, different types of nursing interventions, but remember their actions that you're going to do to try to achieve those goals or expected outcomes. So they should be directly related to that. Okay, so planning is not complete until the plan is documented and becomes a part of the patient's medical record. So the nursing care plan is a documented outline of the nursing care that's going to be provided for your patient, right? So you have to document the care plan. So all those things we've talked about up to this point. Um, so like I said, typically your registered nurse is the person that should be the one that's writing or documenting the care plan. In most healthcare settings, the registered nurse is the individual that's writing or documenting that care plan. Now, in some long-term care facilities, they might have an LPN to do that, to develop that plan of care. But if that is happening in a long-term care, then before it becomes a part of that medical record and put in a chart, then it has to be reviewed by a registered nurse, reviewed and signed off by a registered nurse um, before it's, put in a chart as a part of the medical record. And then the plan of care should be reviewed and updated every 24 hours. All right, question 5. A nurse has established expected outcomes for an assigned patient. The nurse carries out this important activity for the purpose of, so the answer is going to be 3, measuring the effectiveness of nursing interventions. So the purpose of establishing expected outcomes um, is to direct the nursing interventions. You also want to maintain continuity of nursing care and measure the effectiveness of your nursing interventions.